I just want to thank everybody and welcome everybody for coming to our special quality rounds today. It's just wonderful to see the big crowd that we have here. I'm going to keep my introductory comments actually rather short because Atul is the one who'd like to introduce our guest Vivek today, so I'll keep it very short. So let me just go through a little bit of housekeeping that we always have to do. There are no conflicts that we need to declare for our talk today. Last call for nominations for people who have seen somebody do really something above and beyond with regard to improving patient safety. So please go ahead and submit the links right there, and please go ahead and submit. We have a couple more days for this. And before we get to today's talk, we have Jeff Schnipper in the crowd too as we continue our series of outstanding speakers. Jeff is going to come talk to us about the Partners PCORI transition study next month. So I hope that you can all please come and join for that as well. Like I said, I was going to keep it short, so I'm going to turn it over to our speakers in about 2 seconds here. But before I do that, as I look at this crowd and I was thinking about the quality rounds today, I just wanted us to all take a moment to realize how lucky we are to work at a place like this. We have folks like Atul and Vivek who come here to train, and they work here. They both worked here. Atul, we're still lucky to have him, and we had Vivek until he went off to go be our Surgeon General here. And they continue to have an incredible broad impact, not just on us, but across our country and across the world, in fact. And I think what makes this place even more special is even if you take their accomplishments and put them aside, which is what I tend to do, when you look at these guys, as people, what they do is they continue to inspire us and continually try to get better. And it's amazing how they do this. They do this with such grace and ease that I still don't understand how they do it. And they're humble all along the way. So I personally feel very lucky to call them both friends and just want to thank them for making the time to come and talk with us today. So please join me in welcoming them.
First of all, I want to thank Alan for letting us put together a joint event, which is both the quality rounds at the Brigham combining with Ariadne Labs research meeting. And so I want to tell you a little bit about Ariadne Labs before we launch into this conversation. We have a relatively closed research meeting, but if any of you are interested, you'd be welcome to participate, where we ask people to join us a couple times a month and commit to doing it through the year. For people who are doing work on scaling better healthcare delivery everywhere. So our goal has been a group of researchers who come not just from the Brigham and the School of Public Health, which founded our research center, which is a Center for Health Systems Innovation, based at the Brigham and the school and the Harvard School of Public Health, but then brings people from all of the hospitals, as well as the schools, including the business school, the Kennedy School, the law school, and then even from other universities and research places and the Institute for Healthcare Improvement to join us in meetings that occur twice a month at this time on Thursdays for an hour and a half to talk through cutting-edge ideas around how we save lives and reduce suffering through scalable solutions for better healthcare delivery everywhere, whether it's a checklist like in surgery or David Levine, who is presenting data from the work that's been carried out at the Brigham on scaling the home hospital, to presentations we've had from the week after that from Call 9, which is founded by a Beth Israel Deaconess emergency physician, which is providing nursing home care support at nursing homes to avert hospital admissions across the state of New York. So it's very cool stuff, and if you're interested, simply email me. You all know how to find me in the partners email system, and we're happy to include you for these meetings and just ask that you participate and come regularly and join the community. I asked Vivek if he would join us for one of our community meetings in order to talk about scaling prevention and treatment of opioid addiction, part of his role as the 19th Surgeon General of the United States. Vivek served from 2014 to 2017. Many of you don't know that the Surgeon General not only has a bully pulpit, but also commands the U.S. Public Health Service Commission Corps, which is a uniformed service of 6,600 public health officers who are serving vulnerable populations in 800 different locations across the United States as well as abroad. And so through his many different channels of influence and command, he, during his tenure, helped address many critical public health crises, including the Ebola outbreak, the Zika virus epidemic, obesity and low rates of physical activity, the e-cigarette explosion. In 2016, he really turned a great deal of focus to the opioid epidemic and launched the Turn the Tide RX campaign. He also issued the first Surgeon General's report on alcohol, drugs, and health as part of mobilizing the nation to address the addiction crisis. We're going to touch on additional areas and themes that he's had along the way. The biggest reason I'm excited to have this conversation, beyond the fact that we get to talk about his learning and thinking and contributions to understanding how we scale prevention and treatment of opioid addiction, is that we're bringing Vivek home. And this is the place where, so to speak, he grew up. He had come as an undergraduate to Harvard. He had gotten his MD and MBA at Yale. And then he came here as a resident in the internal medicine program. Upon finishing residency, he then joined the faculty. And it was while he was on faculty that he was tapped to take on this role. So we're going to talk a little bit about that pathway as before we dig into the opioid work. But please welcome Vivek, our 19th Surgeon General, home. So first, I have to congratulate you. You just had a new baby, your second child.
I did, yes. You guys hear me? I did. Thank you, Atul. My wife and I were blessed 8 weeks ago to have our second child. We have an 18-month-old at home and now a 2-month-old. So life is busy.
Yes, it's awesome. And I wonder if you could tell us how you ended up at the Brigham.
Well, you know, it's interesting. I came to interview at the Brigham immediately after interviewing at UCSF. And I remember interviewing at UCSF, and they took us to the VA, which for those of you who have interviewed there know that it has this beautiful view of the bay. And of course, this is all intentional, right? So they showed us this slideshow, and there were two back-to-back slides of San Francisco in the winter and Boston in the winter. And they said, we think after this slide presentation, the choice should be clear. And I flew to the Brigham for my interview, and it was 18 degrees here when I landed. And I thought, oh my God, like, why would I want to come here? But I had the most magical time when I was here, starting with the dinner that I had the night before, the interviews that I had, the faculty that I met, who just, everywhere I went, people were kind, you know, in terms of programs I visited, but there was just something intangible that was very special about the people here. At many places, I felt that the programs would support me in being a doctor, in being an academic physician. At the Brigham, I felt that they would support me in becoming the person I wanted to be, regardless of what that looked like. And as someone who was relatively undifferentiated at the time, that meant the world to me. So that's ultimately what made my decision to come here.
Well, we've got Howard Hyatt in the front row here, who's been an icon and an important part of the Department of Internal Medicine. And I point him out because I think one of the things that also brought me here was there is a commitment to impact in the world that is part of the training here that Howard helped bring when he helped people like Paul Farmer and Jim Kim figure out how they could go through medical residency here while at the same time building Partners in Health. And I'll just point out that this was an internal medicine intern class that included not only Paul Farmer, who founded Partners in Health with Jim Kim, and Jim Kim, who's now the World Bank president, but also had Mark McClelland, who went on to be the head of the FDA and then the head of Medicare, and brought in a Republican administration Part D, which brought drug coverage and implemented it. and then had Tim Evans, who's like the piker in the group because he only became the Assistant Director General of WHO, and then the head of BRAC in Bangladesh, and you had Chris Murray, who was the founder of the Global Burden of Disease measures that we all use to track our progress nationally and find out that we're not ranked all that high. And that was just one internal medicine class. And that kind of capacity and inspiration for being a place that we could have and focus on that scalable impact is really critical. And I want to fast forward to the moment when you got asked to consider being Surgeon General. And I want to put it in a little bit of context because it was at a time when another one of our heroes of our community, Don Berwick, who's on the board of Ariadne Labs, founder of Institute for Healthcare Improvement, someone who is really one of the founding leaders of the patient safety and quality movement, who has probably single-handedly saved more lives than just about anybody I know through the kind of scale of improvement of quality that he's driven across the United States and the world, got labeled Dr. Death for saying nice things about the UK's National Health Service single-payer system. And that was enough that it doomed his nomination as the Director of Medicare and Medicaid for the Center of Medicare and Medicaid Services when he was proposed by the Obama administration for nomination. They did not end up calling him up to get his testimony before the Senate, and instead did a recess appointment, which is a workaround, which allowed him to be temporarily, for 17 months, the Director of Medicare and Medicaid, where he was phenomenally successful and had a tremendous impact. But in this backdrop, after all this has happened, you then were nominated. And I remember we talked about this, and you had your questions about whether this was going to be the wisest thing to do. It was, I think, at least a year where your nomination was up in the air. No one was calling you to have a Senate hearing. And the gun lobby, NRA, firmly opposed your nomination. Quote, Vivek Murthy is a serious threat to the rights of gun owners. And it was because you'd been a vociferous supporter of gun control legislation and treating gun violence as a public health issue. Now, I want to ask you, how did you handle that? How did you finally got to walk us through how you decided to go ahead, you're waiting, you finally get a chance for Senate testimony. How did you handle this attack and this question and decide how you'd handle it in being able to move forward?
Well, it was let me just say it was a long process, that I went through with a lot of sort of ups and downs. But it started on July 10th, 2013, when I received a call from the White House asking if I would be interested in serving. And it was not a call that I expected. This was not a position I had sought or thought seriously that I would ever serve in. Honestly, I was somebody who didn't think government was a place where I would ever serve because I thought of it as a inefficient way to create change in the world. Some may argue that's somewhat accurate given what's happening right now in our country. But the point is, this was not a path that I thought I would take. But after I was nominated, there were questions that were certainly raised, about statements I had made around guns. But those weren't the only questions that had come up, because I was, as all things go, I was an unusual person to be nominated to be Surgeon General.
You were 12 years old.
I was. So that was one piece of it, is that I was 36 years old when I was nominated. But I also had a different sort of path that I had taken. So I hadn't spent my entire career focused on academic medicine and on publishing, valuable though that is. I had taken a different path and had practice and some teaching, but had also worked on building a technology company. I had gotten involved in doing policy and advocacy work to organize physicians to play a larger role in advocating for policies that would benefit their patients. And that wasn't the typical profile of someone who's nominated for this position. And then to add to that was the statements I had made around gun violence. And the truth is that I had not actually done much or spoken much about gun violence until 2012, when we had the horrific shooting in Newtown, Connecticut, where we lost so many young children and several teachers as well. And I looked at the efforts that we had made as a country up until then, and the efforts that we were making then to create change, all of which were falling flat. And I felt very frustrated by it. And I stated something very obvious, or something I thought was fairly obvious on Twitter, which is I said it's something to the effect that gun violence was a public health issue. And my view in that was that whenever you have large numbers of people dying for preventable reasons, that constitutes a public health issue. I know this is rocket science to many of you. But there were people who took issue with that. My reading of that is I don't think people really took issue with the basic fact there. I think what they worried about was that this was moving the issue of guns and gun violence and gun rights into the realm of a healthcare debate, which made some folks uncomfortable. But the way this came about as a problem was somewhat insidious. It didn't happen the day I was nominated. It didn't even happen, actually, as in the lead up to my hearing. I actually had my Senate testimony. I was asked about this by senators. I answered their questions. And by the end of the hearing, we had all felt pretty good about where things were. But shortly after that, the NRA and one of the senators on my committee decided that they wanted to make this an issue. And when the NRA wants to make a nomination an issue, they can either just oppose it, and step back, or they can oppose it and score the vote, which means that in the A, B, C, D, F rating that they give senators, that they will factor that vote into the grading. And so when they score a vote, that's seen as a signal that they really care about this vote, and they are pushing senators to support their position. And they announced that they would score the vote. And so that immediately sent a number of senators, Republicans who had been contemplating supporting the nomination, as well as Democrats, actually, who were up for re-election. It sent them from the yes category into the probable no category in terms of the vote. And by all probable causes, it seemed like there was no way that the nomination would move forward. You asked how I handled it at the time. It was tough. I had never engaged in this kind of process before. I was familiar with this type of politics to some degree, having done some advocacy work. But I had to ask myself some really important questions at that point, which is, number one, it seemed unlikely by everyone's account that this would actually happen, my nomination being confirmed. And so did I want to actually stick it out until whenever this sort of dwindled out and ended? The second thing that I'd ask myself is, do I want to subject myself to more public scrutiny? Is not the right word, because scrutiny is okay, but to more public commentary, much of which I knew would not be based on fact, as it is for many cases. It was true for Don Berwick as well. And I remember actually sitting down the day the NRA announced that their opposition, the day that senators, sort of moved away from the yes column. I remember sitting down with President Obama's team and asking them very bluntly. I said, "Do you want me to withdraw my nomination?" And what they very clearly said to me is no. They said, if you want to, we would reluctantly accept it, but we are strongly urging you not to do that. And it wasn't because that was a politically expedient thing to do. Everybody around them was telling them the expedient thing to do would be to just cut and run, because why do you want to spend political capital on an unlikely scenario? But the president had also been deeply affected by Newtown. In fact, when many people have asked him, what is your greatest disappointment of your presidency, he will often talk about Newtown as a time when he was disappointed that as a country we could not pull together in that time and actually pass sensible legislation. So, they were happy to stand, they were willing to stand behind the nomination. And for me, it finally came down to one decision, which is I had to ask myself, will I be able to look at myself in the mirror in the morning if I make a decision that's based in fear here? If I step down in the face of an attack on a principle that I believe to be true, which is number one, a principle that we should all be able to speak our mind, and second, a principle that we should be able to state facts without retribution, and that we should be able to have a debate that's honest and and fair. And so that kind of made the decision for me, and that led to a number of months. It was a 13-month long confirmation process. And again, very few people thought it would actually, happen. But there were a lot of ups and downs. It was a lonely year, I'll tell you honestly. I was not allowed to talk to media. There's just, that wasn't unique to me. It was standard for all nominees. And I wasn't really allowed to engage very much with outside groups. So it was a very lonely and isolated year. But it really made me dig deep and think about what my resources were, what my sources of strength were. It made me look around and really value the people in my life who were there for me. A friend of mine years ago once told me, he said, a true friend is somebody who remembers who you are even when you forget. And, during that year of hardship, there were many times when, I felt lost, when I wasn't sure if I was doing the right thing, when I felt like I wasn't sure what was going to happen. And it took true friends like that to remind me of why I made that decision. And I'm so grateful that not only that decision was the one I chose, but that I had that support around me, because ultimately when my confirmation did come through.
And what pushed it over the line?
Well, it was a couple of things. One, there was a tremendous amount of mobilization from the community that ended up happening, and from somewhat unexpected sectors, around this vote, which put pressure on senators. There were also losses that the Democrats sustained in that midterm election in 2014, which, as some would put it, freed them up to take a vote like this and to oppose the NRA, on a vote. And so those two things, and then also there was really a strong leadership from the White House and from Senator Harry Reid at the time, who was the Senate Majority Leader, who pushed to make the nomination a priority during the lame duck period, and so it actually got a vote. So those things came together to ultimately make the vote happen.
There was one thing that you said that I think was also critical in helping allay the concerns of conservatives, which was you repeated a couple times so people understand, I do not intend to use the Surgeon General's office as a bully pulpit for gun control. And that was important, but it was also reflects some of those compromises that you end up making to go into public service, and a choice along the way. If you had your druthers, you might have wanted to, I don't know, one way or the other, and you spoke out when you did get the bully pulpit to, repeat to people, gun violence is a public health issue, and it was very noticed that you did say that, and that you got that opportunity. But
I want
to ask about compromise.
Yeah.
What's it's an important part of public service is having to figure out how to compromise and reach everybody, but it turns a lot of people away from being willing to jump into office. And I wonder if you could comment on that.
Yeah, it's a great question. And, I think one thing you realize very quickly when you get into government, I think at any level, is that you have to be able to work with people who really disagree with you at times, who may attack you at times. You have to be willing to give a little in order to come to a place of common understanding so that you can support your initiatives going forward. For me, the statement that I made around not using the Surgeon General's office as a bully pulpit for gun control, what I was actually stating, for me actually that wasn't so much of a compromise as it was actually stating what my plans were, and already had been, and what I had said actually in my confirmation hearing, which is that I had a certain set of issues that I wanted to focus on. I had to make tough choices about picking a few, and I was making those in part based on what was causing the greatest number of deaths in the United States and the greatest burden in terms of morbidity. My intention was not to advocate for people's, that we wholesale take people's guns away. But to me, that was not incompatible with recognizing that gun violence is a public health issue, and recognizing that it's an issue that deserves our urgent attention legislatively and otherwise. Now, this is where I think things get dicey sometimes in D.C., is that there were some people who interpreted that as thinking that I had a gag order on me, that if I even uttered the word guns, that somehow I was in violation, of my Senate testimony or this and that and the other. I certainly didn't view it that way. I viewed it, in fact, as my doing what I said I was going to do, which is to prioritize other issues, but to certainly comment on not just gun violence, but any issue that came before me, as I had to do, when I was in office. But listen, if compromise, I know that compromise feels like a dirty word these days, and people increasingly feel like they need to vote for politicians who are not willing to compromise. And I would say that if you have somebody who is unwilling to compromise, you have to ask really, what does that mean? If that means that they're not willing to listen to another side, if that means that disagrees with them, if that means that they're not willing to change their mind as facts and circumstances change, if that means that they're not willing to work with someone else to give a little so that they can get a little that would ultimately benefit their constituents, then frankly, you should really think about whether you should vote for that person. Because, and the thing is, like, we can blame politicians for this on the one hand and say, gosh, they should get together and work together more across the aisle and compromise more. But what they are reflecting is voting patterns of their constituents. And we say we want people who want to compromise and who can work together across the aisle, but we don't vote for people who actually behave that way. And so at some level, I think we have to ask ourselves, does our vote really,
You don't have one anymore.
Old reflexes die hard. But we have to ask ourselves if our vote really reflects our values. And this is, I think, part of a much bigger issue, which is around voting and values, which is, we can complain again about the state of the country. But again, what are the values that we want to see reflected, like in the people who occupy elected office? And are we actually supporting people who reflect those values? And if you don't find that there's somebody who reflects your values, are you thinking about running yourself? Which is something that I think everyone should be thinking about in this day and age. One thing I learned in DC is that we don't have enough talented, smart, thoughtful people who are running for office. We have some really good ones in office, and I don't want to cast Congress with a single brush and say that everyone is a certain way. There are some very good people in the legislature. There are some extraordinarily talented, committed, dedicated people who I've worked with in the administration as well. People whose names you don't read about in the papers, but who are there working 90, 100 hours a week to make sure that we are actually expanding access to healthcare, that we're doing what we can to improve quality of healthcare, et cetera. So, but we need more people like that in government. So please don't make the mistake that I made when I was in training of thinking that government's not a place for me because it's not a place where people who want to create real change should go. It is a place where real change can happen, but it's also a place where real hope can be given. Because when you see what happens when we don't have enough talented people in government who can come together around a core set of ideals and move solutions forward, people lose hope in public institutions. They lose hope that the government can actually accomplish anything, that it's relevant to their day-to-day lives, and they end up lodging protest votes. That's why we need better people to run for office. And so I think you should look in the mirror and think, am I that person? Could I be that person, and should I be? Alan Kachali, I'm looking at you.
We're here to try to talk about one area which actually has not so far been turned into a partisan weaponized issue, which is opioids. And I want to dig into that a little bit. First of all, we're in an extraordinary place. We're now at more than 64,000 deaths from opioids in 2016. That's more deaths than at the peak of the HIV/AIDS epidemic in 1995 before we had treatment. And it is heavily related to our own practices as clinicians that has helped contribute to it. I wonder if you could talk to us about how you think we got here. Oh, and by the way, I want to help the audience know we're going to talk for another 20 minutes or so, and then we'll open it up to questions. And following our Ariadne way of doing things, we make these longer meetings. So we'll go until about 80 minutes or so. So sometime quarter after the hour. So we'll be plenty of time to get to Q&A at that point too. So yes, how do we get here?
So I think we got here really on a path that was paved with good intentions, but there were multiple paths that converged to result in the epidemic that we have today. Sometimes we like to say there's one population to blame, whether that was doctors or pharmaceutical companies or policymakers. But the truth is that we all had a hand to play in it. As clinicians, we really didn't understand how addictive opioids were. That's the bottom line. And I remember being taught that these weren't addictive as long as they were given to people who had quote unquote legitimate pain. We know that that's not entirely not the case right now, but there were many people who practiced under those auspices. We also, we had pharmaceutical companies that were aggressively marketing these medications, often underplaying some of the adverse effects and the addictive potential. This was combined, of course, with a profound lack of treatment that we had, treatment facilities and options that we had in the country for people who were in fact diagnosed with opioid use disorder. And all of this has to be looked at against the backdrop of how the public understood and thought about addiction as an illness, which is that they looked at it as a heavily stigmatized disease, a disease that was entirely one of choice, as opposed to a disease that was driven by biology, even though choices were involved. All of these factors really combined to lead to the epidemic that we see today. And that's why I think as we think about solutions, we have to think about how all sectors play a role in coming together to address this. It bears mentioning that for decades, we took an approach to dealing with addiction that was largely driven by the criminal justice system. We thought we could jail and incarcerate ourselves out of the crisis, and that turned out not to be the case. What happened is we filled up our jails at tremendous cost, not just to taxpayers, but more importantly to human beings. And we have stolen the lives of so many people and their families because of that tendency that we had to focus on a criminal justice approach, particularly communities of color and poor communities. But if we want to really address this crisis, we have to think about the role of physicians, nurses, and dentists. We have to think about policymakers, about law enforcement, about employers. This has to be a multi-pronged solution. The reason I mention this is because complex solutions aren't always well, how do I put this kindly? They don't always play to the strength of policymakers in DC, who are looking often for more targeted, focused solutions. So for example, if there's an illness, people want to know, how can I fund a vaccine or an antibiotic to deal with it? People want to have discrete, clean solutions for the problems that arise. The opioid crisis does not have a clean, simple solution. There are actually multiple things that we need to do. One of my concerns as we look at how we are doing that as a country is I think that the response has been very fragmented and it's been piecemeal, and it often hasn't been sufficient in either breadth or in depth. And I think that continues to be a problem that we need to work on. Otherwise, we're going to see numbers that continue to grow in terms of overdose deaths.
So I want to try to separate into three parts. One is the kinds of variation we're seeing and understanding why the variation's there. The second is prevention of more people becoming addicted and what we can do in the healthcare system to drive prevention, and then management of chronic opioid users and people who have addiction. And so maybe we'll break it into those three parts. So first on the patterns, so recently a Lancet Commission report came out that pointed out that the United States is the only place in the world with this massive opioid epidemic. In Europe, opioid deaths are very low, and rates of untreated pain are very low. So there's a sense that the balance is closer to right in many European countries. But then there are also significant parts of Europe, lots of Latin America and Sub-Saharan Africa and Asia, where there's massive undertreatment of pain with little access to narcotic treatment or pain management along the way. And so it suggests the U.S. has a very particular problem. So I buy the idea that it is partly us, but it's been also deeply affected by the way that opioids have been marketed and managed here. I'll add in one component, though, just to echo what you said. I did not know when I'm prescribing opioids for my post-op patients, they frequently ask me, I'm not going to get addicted, am I? And I would say, absolutely not. The rates are incredibly low. I never once actually looked up that was true. I never really researched or tried to find what the data was on this. There wasn't that much out there, but the data was out there. And in the surgery literature alone, there was already evidence that when we prescribe an opioid narcotic to people who are naive to narcotics, getting it for a new surgical procedure, that if we give them a 1-week supply, 3 to 10% 1 year later will be on that opioid. That is how addictive it is. And I had no idea, and I was fueling part of this crisis. We all were along the way. We'll talk about the changes we're pursuing here and people are pursuing elsewhere around prevention. But one thing I want to try to understand is some of the variation that I don't understand, I wanted to ask you about. So I come from Ohio and rural Ohio, where this is a massive problem in southeastern Ohio. And it's an area, it's one of the poorest counties in Ohio where I come from, also West Virginia, where you have what's called the deaths of despair because you have economic stagnation, you have high heart disease, high alcohol, high gun violence, high opioid use. But Massachusetts is no different. So the deaths per 100,000 in Ohio is 39 per 100,000, but in New Hampshire is 39 per 100,000. Massachusetts is 7th from the bottom at 33 per 100,000. Now, our gun violence numbers are not what they are in Ohio and in West Virginia. Our heart disease rates, however, are. We're down at number 45 out of 50 in the country around our heart disease deaths, despite our big healthcare capacity. We have better marriage rates, better education, and yet opioids is hugely an epidemic here, just as much as in the county where I grew up in Ohio. And I really don't understand why that would be. Do you have any clue? Like, why is it so bad in this area? And I'll tell you how bad it is. So Chuck Morris, I don't know if he's here. Chuck, are you here? So Associate Chief Medical Officer told me that right now, up in Shapiro, we have more patients who are here for cardiac valve surgery, for endocarditis related to drug use, than we have people here who are here for cabbages. That is how bad it is in our own community. Why is it so bad here? Any idea?
I mean, short answer is no. This has been a vexing problem to figure out, and it's been a problem that's been discussed for a while. People, when you look at the maps of opioid use disorder, overdose deaths in particular over the last few decades, you see hotspots like in the Appalachia region in West Virginia, in particular. You see another hotspot in New Mexico, and you see that they started to spread from there. But why did they begin there? The argument that this is about economically disadvantaged populations doesn't seem to be entirely the explanation, because there are other regions where economic challenges and poverty rates are in fact just as high or higher, but they don't seem to have the same challenge. People have looked at trafficking routes in terms of the trafficking of illicit narcotics to see, are they overlapping with these areas? Also doesn't seem to be a clear explanation from looking at trafficking patterns. So this continues to be a somewhat perplexing question of why is this bad in the places where it is bad. One thing I think that's important is you touched on not just opioid use, but also alcohol as well. And I think one important thing to recognize, and we've been reading about opioid addiction and opioid use disorder in the papers almost every day now, right, for years because of how bad it is. But when we issued the 2016 Surgeon General's report on alcohol, drugs, and health, one of the things that we pointed out was that the majority, it turns out, of cost and in terms of lives impacted from addiction broadly as a category comes actually not from opioids. It actually comes from alcohol. And so we think about alcohol as, yes, it's a problem, but probably not as bad as the other things that are out there. But alcohol, I think, unfortunately, has become one of those issues that we have started to take our eyes off of as we have turned to focus on the raging opioid epidemic. And I worry about that because I think in doing so, we may lose an opportunity to save many lives that are still being impacted by alcohol use disorders each and every day.
So let's jump into the prevention function. There are a few things that are on the list of recommendations that I've seen come out of your office, the FDA, and others. I wonder if you could hit for this group the parts that you feel are most important, and what should we be doing to prevent addicting new people naive to opioids? What are the proper practices we should be counseling our patients about or thinking about? And you even sent a mailing to every physician in the country trying to bring home some basic points.
Yes, let's tell you somewhat parenthetically that I thought that letter would take me a couple of weeks to write and send out, but I forgot about government bureaucracy, and it took like 9 months. So I'm sorry some of you got it later than intended. But there are when we issued the 2016 report, we actually dedicated a whole chapter to prevention, recognizing that many reports have focused on treatment, but as a country we haven't done a great job on prevention. When it comes to opioids, I think there are a few key things that we can do. Number one is to think about our prescribing practices, right? So in the letter that I sent, we had also included a pocket card that reflected some of the recent CDC prescriber guidelines. And in there, there were certain recommendations about, number one, moving away from using narcotics for chronic pain. Number two, reaching for non-opioid medications to treat pain, recognizing that we are now seeing more studies indicating that courses of non-opioid alternatives can often be just as beneficial, sometimes in some cases even marginally more beneficial than using opioid treatment, low back pain being one example of that. We had also recommended strongly to avoid prescribing opioids and benzodiazepines together. If you do need to prescribe opioids for acute pain, trying to limit that to a 3-day course to begin with is what we had recommended. And there's an interesting data. If you look at some of the data that actually Atul referenced earlier, the point at which, if you look at basically the number of days that people are written a prescription or given opioids for versus how many of those people are on opioids a year later, the point at which the curve seems to take a swing upward is actually around 3 to 4 days. So the point being that if you're on opioids for longer than 3 days and you're opioid naive, there's a much greater chance you'll continue to be on it at a year compared to if you have a less than 3 day supply. So shorter prescriptions are better. What we essentially were saying was to start low and go slow when it comes to opioid prescribing and to reach for alternatives first. With that said, and there are certainly a lot more details there, which you can actually find, on the CDC prescriber guidelines. There are limits around the number of morphine milliequivalents that you want to try to keep in your head, as a threshold. 50 being one, 90 being more of not an absolute one, but a real sort of red flag level. But these basic tenets around prescribing are incredibly important. But another thing I think that's really important for us to do around prevention is actually patient education. So, and I think we have some experience with this in the realm of antibiotics. So many of us can remember a time when children were often prescribed antibiotics for every ear infection they got. And then we realized that wasn't actually good medicine, that wasn't good practice. But what had to happen to actually change practice there, and we're not at a place of perfection there by any means, but we have certainly improved compared to years past. But what helped was a combination of both clinician education but also patient education. So now when I talk to pediatricians, they say, we have more patients who come in saying, I'm worried about my kid, I think they have an ear infection, but I also heard that antibiotics aren't always good for ear infections, or does my kid really need the antibiotics? And that was not necessarily true 15 to 20 years ago. So similarly here, when it comes to educating the public about the dangers of opioids and also about pain alternatives, that is incredibly important. There's a last piece of this, though, on the prevention piece in terms of what we can do, which is, I think, trying to change, actually two pieces. One is to change, culturally speaking, how we think about addiction. Because the fact that people still look at addiction as a stigmatized illness, as a disease that reflects some sort of moral failure or character flaw, means that they're often reluctant to come forward at the early and late stages when they're actually struggling with opioids or with other substances of use. And that prevents a real barrier to us as clinicians identifying people who are having trouble and getting them to treatment quickly or modifying their opioid prescriptions. So that piece around shifting culture, how do you do that? Shifting culture is really, really hard. But it starts with how we talk about substance use and addiction with our patients, the language that we use, how we talk about it with our peers. You may think that it doesn't make a difference, but patients will take their cues often from how their clinicians talk about a condition. There's one last thing I think that's important to mention that doesn't get much discussion when it comes to prevention, which is actually thinking more upstream in the chain, to thinking about community-based prevention that often starts in schools. In chapter 3 that I mentioned in our 2016 report, many of the programs that we detailed there were programs that have been implemented and studied in elementary schools, middle schools, and in high schools. What they have been able to demonstrate, although not certainly at the scale that we would like, but at a modest scale, is that these interventions, school-based interventions, can have a dramatic impact on the rate of substance use later in life for children. And when I say significant, I don't mean like a 2% reduction. I'm talking about double-digit reductions, and not like 10, 12, 14. I'm talking about like 30s, 40% reductions in substance use disorders later in life. One of the challenges is that the payoff comes later, right? And traditionally, you know, as far as public policy is concerned, we are unfortunately in an era where people are always looking for short-term returns. But these programs work. They take some time to work, but they work. If you look what they're doing, it's actually quite interesting, which is another window, I think, into what is contributing to our addiction crisis, which is they are not in the old school model of beating kids over the head and telling them drugs are bad. That's not what these programs are actually doing. In some cases, they're actually not talking about drugs at all. What they're actually doing is equipping students with social and emotional learning skills, with tools to actually identify, regulate, and manage their own emotions, and by extension, deal with and manage their own stress. This ends up being important because I have come to believe through the conversations I've had with community members and looking at some of the science out there that the emotional pain that people are experiencing, I believe, is an important driver of what leads them sometimes to use opioids for the first time or to continue using opioids. You know, when we, as human beings, when we're in pain, we will seek to alleviate it. And the question is, what do we reach for? You may be fortunate to reach for a friend or a family member. You might be the kind of person who, when you're feeling down, you go for a run to lift up your spirits. But, you know, that's not always a choice for everyone. Some people will reach for alcohol, others will reach for food, others will reach for violence, and this is an important contributor of violence to our emotional health. And drugs also become something that people reach for that help to fill that void, albeit temporarily. And so I think that these upstream prevention programs, they're remarkably cost effective when you look at the data. Some of them save up to $64 for every dollar invested in terms of reduced healthcare costs, improved economic productivity, reduced criminal justice costs. But again, the question is, why aren't we investing in these programs, in studying them more, in helping to scale them, and getting them to communities everywhere? And I think that reflects a much larger problem we've had in health policy, which is around an imbalance in how much we invest in treatment versus prevention across the board. Is that going to change? Well, I don't think it's going to change solely based on legislators in DC. I think it will change if people demand it. Because finally, this notion that we are only short-term in our thinking, there is one example that I think that tells us that may not entirely be the case, and that's, I think, the case of breast cancer research. If I invest $10 million in breast cancer research today, it is not going to pay dividends in the next quarter or even the next year. That's going to take many years to pay dividends. Yet if you go to Congress and you try to build support for expanding our research investment in breast cancer, you're not going to find too many people who oppose that effort. Now, that wouldn't be the case if they were locked into short-term thinking, but I think members of Congress are more locked into what their constituents will support. Right now, prevention doesn't have a lobby, so to speak, but it needs more advocates, louder voices to call for investments. And I think particularly when it comes to opioids and addiction, this is a place where we desperately need to invest in these upstream prevention programs. But right now, we just don't have the federal funds to do that.
I want to highlight a couple of the things that you emphasize and add to them. That the evidence, I think, from your office, CDC, and others include not only limiting the prescriptions and recognizing that when we were prescribing for a week of treatment for short-term pain, like from surgery or other kinds of things, that patients were not even using 80%, and much of that was being diverted into the illegal stream. So the counseling to patients when we are giving much shorter courses that I've learned to be important includes counseling them to expect adequate pain control, to counsel them not to expect no pain, but to expect adequate pain control in order to be able to function, to be able to sleep, eat, ambulate, and that function is a better indicator of how people are doing. Are you able to function? Than asking them about their pain level. The second part is that you have to teach them how to dispose, and the recommendations for narcotics for disposal are that you can flush unused opioids down the toilet, bring it to a pharmacy or another approved disposal site, and there's a couple other disposal methods as well that are recommended, but I find those are the ones that people use most commonly. And then a further step, which I really think is important that the Brigham and Partners is executing on, is being able to make it more electronic to be able to check the PMP, be able to check whether people have multiple prescriptions or not electronically, and make it easier for us to do that as part of our prescribing. And that's coming with a new issuance of the Partners e-care system, and have the ability to do e-prescriptions. And in New York State, where this is now throughout New York State, that has been incredibly effective, because people are unwilling to give very short prescriptions because you're worried someone will be in pain and I have to fill the prescription, and now I got to make them drive back from New Hampshire, pick up a paper prescription to go get 20 more pills. The e-prescription capability would let you write for very short courses, and then if they need it, send a prescription, and it's easier to trace and make sure it's not diverted and all of those things. And so that's part of what's coming with the Brigham and Partners strategy, and I commend the team who've been making that happen. The last part I want to go to, and then we'll open to questions, is the management of those who are on who are addicted. We already know that people who have been on chronically on opioids for 3 months are 30 times more likely to die in the next 5 years than those who are not on opioids. Tell us about the management of opioid addiction. We're hearing much more about medically assisted therapy. What do you think are the critical parts of the strategy that we should be knowing about and advocating for and thinking about with our own patients when we see that people are chronic users or showing signs of addiction?
Yeah, so we have to. This is an area where we have to work simultaneously on prevention and treatment. And on the treatment side, number one, the first thing to say is that medication-assisted treatment with methadone, buprenorphine, with naltrexone, these are strategies that have a fair amount of evidence behind them. In the case of methadone, going back decades, and these are strategies that are proven to work when it comes to reducing overdose deaths, when it comes to improving employment, reducing crime, reducing the spread of infectious diseases like Hep C. There's good evidence that we should be supporting these strategies. And so the question is, how do we expand access to medication-assisted treatment? I think part of what we need to do here is, number one, we have to integrate the delivery of MAT into our existing healthcare settings, particularly primary care settings. But given the extent of the addiction crisis now, we have to have a no wrong door policy when it comes to getting treatment and getting MAT in particular. This is especially important because if you look at the treatment options that are out there, the vast majority of them do not actually offer MAT. They, in fact, don't offer evidence-based treatment. Many of them are based entirely on abstinence, and they're following models that are not proven. But they are costing patients tens of thousands of dollars a year. And this is a massive waste of money and effort, and lives are being lost in the process. So I actually think on a policy level, one thing that we have to do is we need to start paying for what works and stop paying for what doesn't work. And that means paying for MAT and increasing our funding for MAT. So MAT is important. Connecting patients with it is important. Integrating it into our delivery system, I think, is essential to improve access to care and efficiency of care. But I also think when it comes to getting treatment, there's a lot of education that we have to do to help people understand that what MAT is and why it works. There are a tremendous number of misconceptions about MAT out there that have a profound impact on policy and on whether people choose to use it. I'll give you a very simple example. When I was in Tennessee as part of the Turn the Tide tour that we did, the campaign that we ran, and when I was in office, I sat down with a group in Knoxville, Tennessee, and it was at a hospital system that had brought together members of the community who were leaders on this issue, including law enforcement folks, a judge was there, and physicians and public health leaders. And I remember at one point the judge raised his hand and he said, and people, again, he was a champion, for addressing this issue. He raised his hand and he said, I have real concerns about methadone. I said, well, what are your concerns? And he said, well, I'm pretty convinced that methadone increases people's sex drive and is leading more people to get pregnant and is leading to more babies with neonatal abstinence syndrome. And so I think that we have to get this drug out of our community. Otherwise, it's going to destroy us. And the thing is, I was in a room with public health leaders and physicians, and nobody actually contradicted him and indicated that maybe this wasn't exactly the case. And he had actually just come from court that morning where he had made a decision to separate a mother from her child because the child was born with neonatal abstinence syndrome and he was holding her to be negligent. And that's a complicated decision which we can talk about. But my point is that this was somebody who was held up as a leader in this effort, and this was his belief around methadone that was echoed by people around him. After that meeting, I had a physician pull me aside and say, look, I understand why you want to get buprenorphine to more patients with addiction, and we think we might be okay with that, but only if it's just a little bit. And I said, well, what do you mean, just a little bit? Because you have a big problem here in the community. And he said, well, if we have more of it, then we'll just open the gates for more buprenorphine providers to come in, and they just see it as a money-making machine. These are the kind of conceptions around MAT that are held by practitioners, by doctors and nurses, by policymakers. And this is a real material impact on whether we can actually get treatment centers into communities, and whether people even come forward to seek out treatment. Many of the people who wanted treatment at the few centers that Tennessee had were telling me that they felt they couldn't go there because they would be shamed by their neighbors and by their community. So that bears emphasis, because all of our efforts, well-intentioned efforts at expanding funding for MAT and improving access will have limited impact if we cannot change how people understand and think about MAT.
I have to say, and then we'll open it up to questions, that I was very uneducated on this subject, and I want to credit learning a couple things that really have swayed my thinking about this from Sarah Wakeman at MGH, Michael Barnett here at the Brigham, and Roger Weiss, who's the head of addiction at McLean. And it was just sending me some basic papers showing that the data on opioid substitution, which is buprenorphine or methadone, is that they produce an 80% plus decrease in drug overdose deaths, period. Proven multiple different kinds of trials, and a 50% decrease in all-cause deaths. By contrast, we're spending a ton of money on rehab and detox beds, which don't have any evidence that they're working. And we're reluctant to give the actual, like, imagine it's 1995 with the peak of the HIV/AIDS epidemic. We've got a cure that works in 80+% of people, and we're debating whether we want to give it to people. We're not even having a discussion about actually mobilizing in a way that's going to actually provide it. Now, I want to give credit again to people around here. MGH built a model in a bridge clinic that has been very successful at MGH. We're going to be opening one here at the Brigham, and have to provide the ways that we're going to be working in our primary care settings and elsewhere to understand how to mobilize and make it easy to routinely provide buprenorphine, methadone, naltrexone as a part of our practice when we see this. And it's just very clear we have been reluctant, even as a profession, to demand that this is part of our skill set. This is a disease that we all see, and we have to not think it's something that some other provider provides. We all have to learn how to provide it and make it available. Let's throw it open to questions, and thank you, Vivek, for opening up this really important conversation. I don't know if there's a possibility of passing around a microphone, or I can pass mine around. Oh, there's one mic. Okay, good. Microphone available. Let's hand it around. Wait, pass it down that way. If you can introduce yourself, say where you're from, and then ask your question.
Hi, I'm Katrina. I'm from the Brigham. There was an article recently released from NPR saying how drug distributors and pharmaceutical companies shipped about 21 million painkillers to a West Virginian town of only 3,000 residents. What's your take on that? What's your thought on that?
And before you answer, if you, I saw a number of hands, maybe we can pass the microphone and it goes on to the next person. So there's one mic over there, and why don't you pass it over to your right? There's some people over that way. Okay, great.
So thanks for raising that. I think that there have been stories like this that we've read about that have really I think, anger people who have said, well, in the face of this crisis, what are pharmaceutical companies doing to not only not contribute to making it worse, but to actually contribute to making it better? And I think that there are two important points here. One is that I do think that pharma companies need to step up to do more. That means not just curbing their advertising of these opioid medications or how much they're pushing them on patients and on clinicians, but I think they need to step up to also help fund treatment for a crisis that they played a role in creating. They weren't the only ones who played a role, but we all have to step up, and do our part. And I think pharma needs to do that as well. The second thing I think that's important, though, is that from an enforcement and regulatory perspective, many of the fines that we levy on pharmaceutical companies for transgressions, we think that they're big, but they are a small fraction of even their marketing budgets. And so for many of them, these fines are just the cost of doing business. They're not true deterrents. And I think that that's a place also where we need to rethink how we are actually enforcing, not just what regulations we have in place, but what kind of penalties we are assessing for infractions of those regulations. Because right now we don't have sufficient deterrents in place, I think, to change the behavior of some of these pharmaceutical companies.
Hi, thank you so much. Duncan Maru, I'm at Brigham and a proud resident trainee, formerly of Dr. Murthy here. One thing I appreciated about you as an educator was that you really expressed a certain spiritual call to address the crises of our profession, and that came very clearly when I was training under you several years ago on the wards, whether it was teaching how to more compassionately do a spleen exam, or when we read poetry, or talking about that we will lose a generation of physicians if we don't address issues of access and equity. And I really appreciate that. And I think that your letter to In Turn the Tide spoke to that spiritual calling for us to say we have to own up. This is our epidemic that we created. And you said it in a nice way that was inviting to us. For me, one related spiritual crisis that we have here in medicine is around institutionalized racism. And I do respectfully disagree with Atul about that. That I do think that the opioid narrative has been racialized in a profound way, and you need not look beyond the oil paintings in the room, all the white men that to not acknowledge that our own institutions are deeply racist. So, to what extent do you think that racialized narrative of that basically white men are the primary victims of this epidemic in implicit and explicit ways, and that immigrants or black people or brown people are the perpetrators? To what extent is that shaping public policy, and to what extent can we address that?
Well, thanks for that question, Duncan. So nice to see you again. The point you're bringing up, I think, is a really important one, and it's actually one that surfaces very often when I've spoken to communities. And it's sometimes framed in a different way, which is, why are we paying attention to this crisis now? Is it because now it's affecting white communities more, whereas before, when communities of color were struggling in the 70s and 80s, we just thought it was okay to put them in jail? And look, I think there is a racial narrative here. I think that there's also I think part of what has driven attention to this issue has not just been the numbers going up, but I think that people in positions of power are now realizing that people they know and associate with are actually impacted. I can't tell you the number of times I've had a conversation with a member of Congress who has started by telling me about their best friend or their friend's son or daughter or somebody that they knew at a very close level who was impacted by this. And I think this is playing a big role in driving the attention that we had to this. And by derivation from that, many of the people who are in power are still, especially at a federal level, are men, and many of them are white. And so we have still not yet come to a place where our government reflects the people that it is serving. And I think until we get to that point, we will continue to see a disparity in the crises that we respond to. I don't think all of that is because people are inherently bad in their intention. I think some of that is just very human. We tend to respond to things that happen to people that we're close to, and we respond in a very visceral way, right? If there was an issue that my mother was struggling with, I would become more passionate about it, and that's my response as a human being. But recognizing that that is the human tendency is why I think it is so important for us to ensure that our leadership in the federal government is diverse, but also our leadership in institutions is diverse, because we can't assume that through sheer force of will that a single individual can capture all perspectives or all sensitivities or cater to all populations. The issue of equity that you bring up in a larger sense, Duncan, I do think has to be central to our calling as clinicians. Whether you're a nurse or you're a doctor, whether you're a dentist or a pharmacist or physical therapist, more likely than not, you came to this work not solely for the paycheck or the social standing, but you came to this work out of a sense of calling, and a calling that involved helping not just people of a certain type, but all people. The reason that I love being in the profession of medicine, the reason that my primary identity is still that of a doctor and will always be that, is because to me this is a community where, while we may disagree about umpteen different things, at the end of the day it is our common value and care for patients, regardless of their background, that pulls us together. That's the value that grounds all of us. But I think that to ensure that the integrity of our profession is maintained, we have to ensure that that value is reflected, not just in the work we do, but in the institutions that we're a part of and that we create. And that means making space for people as well. When I was in office, I was very cognizant that I was the first Asian American to serve as a Surgeon General. I was also very cognizant of the fact that I was a man. And what that meant was that, to me, what that meant, and this was a personal thing, is that in the same way that people, whether it was the president or others, had created an opportunity for me to serve, someone from a different background, it was important for me to try to create those opportunities for others. And that meant in creating more spaces for women to serve in leadership positions in our office, and for people who traditionally had been underrepresented in the office. So I'm very proud that we had a diverse office, but that was one office. And as a profession, I think our challenge around equity is much greater. But one last point of caution I want to make on this issue, Duncan, which is that I think we have to be careful when we point out these types of inequities about understanding, or I should say about ascribing intention. Because what I have recognized is that certain people, for example, respond very viscerally to the term racism, right? Some of them think, well, that means that if you say that something I'm doing is racist, that means that I intentionally don't like people of color, right? And we know that that's not always the case. We know that almost by definition, institutional racism or structural racism happens in spite of our conscious intention. It happens as a product of history and the way institutions have been built and power structures exist. The reason I think this is important is because if we want to have real dialogue with communities, especially with people who disagree with us, we have to be able to some extent separate what we're seeing from the intentions that people may have, recognizing that they may be actually quite distinct things. In some cases they're not. In some cases people actually have legitimate views that some folks are inferior to others. But I find more often than not, the people don't actually hold those views on a conscious level. They actually want to do better. They're not always sure how. They don't always recognize that there's an inequity that persists around them. And that's why I think it's so important for us to think about how we start these conversations in a way that can invite people in, and without necessarily assuming what their intentions are. But I think I'm glad you raised the question, because more and more, I think we are going to see issues around equity be part of our national conversation, not just around health, but around economic justice, around criminal justice, around so many issues. And I think as a profession that is so deeply grounded in, as I see it, a moral principle around equity, I think that we can and should be leaders in that conversation around how to make equity reflected in all aspects of our society, not just in healthcare, but elsewhere. Now, that's not easy. That means speaking out on issues where we can get branded as political. It means speaking up at times where people may find it inconvenient. But if we can do that kindly, compassionately, but firmly, in a way that invites people in, I think we can be, as a profession, a leader in starting conversations that really need to happen, and that hopefully will become the foundation of real substantive change.
There's another microphone out here. Who's got it? There you
Hi,
go.
Vivek. Welcome home. Really nice to see you, and really, really enjoying this conversation. I have two questions for you. One of them specifically about opioid treatment, and the other one a more general one. So the first one is, what I'm seeing a lot of as a hospitalist on the wards are not just people who are using illicit opioids and often have some acknowledgement that they have an opioid use disorder, but patients who have years of chronic pain, who are on high doses of prescription opioids at very high doses, have very large tolerance, and have a lot of what I would call aberrant behaviors and other signs that they probably really do have an opioid use disorder, but are in complete denial that opioids are the problem. They will tell me what the problem is, that they have chronic pain. And I was wondering if you have any advice, wisdom from your time being around the country about how to best approach those patients and try to have them realize that the problem now has become the opioids themselves and that they actually need treatment, including medication-assisted therapy. My second question is a more general one, which is, what do you see as the most effective ways that we as providers can be advocates for change in our healthcare system, or even more generally? We're all looking for ways to be the change, to make the change that's going to happen in this country, and trying to figure out what the most effective ways are to do that. So, and thank you again.
Well, thank you, Jeff, for those questions, and it's so nice to see you again as well. You pointed out a real challenge around patients who are on high levels of opioids for a long period of time. Many clinicians, I think, around the country are struggling with how to manage these patients, and the truth is, like, there's no simple way to approach this problem. What I do think that we have to be mindful of is letting the pendulum swing too much to one extreme, where we are suddenly cutting off opioids from everyone, saying that these are dangerous and no one should have them. I see that starting to happen. Not starting to happen, it's already happened in many places. There are ERs that have signs outside that say, we won't dispense opioids to anyone here. There are, Medicare, as some of you may have read in the news recently, is now moving forward, or looking to move forward a program that will essentially stop paying for opioid prescriptions that are longer than a short few days. And all of these are grounded in good intentions and understand where they're coming from, but what they sometimes need to account for is the fact that if somebody is on a massive dose of opioids and has been for 5 years, and you cut them off immediately, you are actually putting them at substantial risk. I'm not just talking about morbidity here, I'm talking about mortality risk. So I think that convincing people, though, that they need perhaps to have their high doses addressed, whether it's through gently tapering or whether it's actually by engaging in an MAT program if they are on large doses of opioids already. I think we have to realize that sometimes as doctors we may not be enough to actually convince people or move people to a place where they're ready to taper or they're ready for treatment. I think what we need is sometimes the help of their families. I think we sometimes need the help of other team members, particularly folks who can spend more time focused on their mental and emotional health than we traditionally have done as clinicians. I think what we're really talking about is behavior change here in some ways, and we know that behavior change is not easy. Anyone who's had a conversation with a patient about elevated lipid levels and tried to talk to them about changing diet and exercise patterns realizes that it's not easy to convince people to change, but it's also not easy for them to keep up that change. So I think that this is an area where it's particularly important for us to broaden our thoughts about what team-based care really is and a team-based approach to addressing opioid addiction. There's one program I came across in Ohio, in fact, and I think they want to keep their program under wraps for the moment, so I won't name where it is, but it's at a prominent institution that decided that what they were going to do with people who were struggling with issues around opioids is that they were actually going to put them through a program and have them see a psychologist first. And they had to think about how to couch that and how to present that to a patient so the patient wouldn't think that, okay, you're assuming that I'm quote unquote crazy And that's why you're having me see a psychologist instead of like seeing me yourself. But what they found, what we're starting to find in the early stages of doing this, was that those early conversations with the psychologists that work with them was really enabling patients to understand what was happening to them, to delve into other sources of pain in their lives other than the physical pain, and to be more open to approaching their treatment than they previously had been. So I think we have to take a bit of a different approach here when it comes to thinking about the role we play, but also the role that others need to play. And then finally, so your second piece was around what, Jeff?
Be better,
advocates. So here, I think advocacy, I think, is incredibly important, particularly from our profession. One of the reasons is that right now, all of us have read about in the paper that faith in public institutions is dropping, right? And it's not just in public institutions, but it's in political offices that we've long had confidence in. It's in individual politicians. It's in institutional leaders. Faith, that has been going down. But the profession of medicine and nursing still actually hold a fairly high degree of trust relative to other professions. And so to me, that with that trust comes a responsibility and a question of what do we do with that trust? We want to continue to provide good care to the patients who are in front of us. But at a time where people are casting about wondering who to trust, what's fake news and what's not, what issues should I actually support, the voices of the people in this profession stand out as voices that need to be heard now more than ever. And that means certainly, yes, talking to legislators to let them know what you feel, what you believe, what you support, what you don't support. But it also means talking to communities directly, whether that means going to schools to talk to parents, about issues you're concerned about in your patient population. It could be around opioids, could be around other issues, around childhood obesity. It means talking to YMCAs and other community groups that have reached to faith-based organizations, as we sometimes used to do here in Boston, to reach the community to talk about important issues. People don't know where to go often when it comes to understanding what's going on with their health. They're turning to Dr. Google all the time. I'm not saying Dr. Google doesn't have some good stuff out there. I turn to Dr. Google too. When it's 3 a.m. and I'm worried about why my kid's not sleeping. I do that. But my point is that when we are having still ongoing debates about, in some corners of the country, about whether vaccines are safe or not, when we're having discussions and disagreements about MAT, when we're having confusion about issues where the data is actually pretty clear, that's a strong signal to us that the trusted voices aren't getting out, aren't being heard. The more you talk to those populations in your community, the more likely they are to be mobilized to make their voices heard with legislators. And that's ultimately the multiplying effect that we can have. As clinicians, we are force multipliers from an advocacy perspective. We can go and speak to legislators on our own, but it is when we get in front of communities that we play the role I believe that we really need to play right now. If you haven't done that before, you might think, gosh, where do I go to actually speak to my community? But literally think about your backyard, like the faith-based institution you may go to, the YMCA that might be in your neighborhood, the school that your child may go to. These are all places where people are hungry to learn about health, and you could be the voice that helps them understand what matters, what issues are on the table, and where their voice needs to be heard as well.
I'm afraid this will be that I won't go on to any further questions at this point. We should wrap it up. But I'm going to add two things to by way of closure. One is that you're reminding me that behavior change, whether it's social change or for your patient who's not ready to contemplate what's happening, has stages. And it starts with pre-contemplation and trying to move people to contemplation, and then contemplation getting all the way to action. And part of it is just having that conversation is the beginning. And although they push back, they've heard you. And being able to be part of a community where we're telling people that you may need help makes it much more likely. The evidence is that it's much more likely each time you do so. You're adding to the likelihood they shift from being in a pre-contemplative state to contemplating making a change. And that's also true about the ways in which we contribute in the community. I want to end with a question for you, which we all wonder about. What's next?
Well, I don't 100% know what's next. I will tell you that my I'll tell you a little bit about the process that I've been going through to think about it, which has been a messy process. But I want to share it with you because I think it's important that we talk about these things. When I left government service, it wasn't by choice. So I was terminated by President Trump. And
Not literally.
And it was, little did I know then that I would be one in a long line of such We joke sometimes that we should have a club, you can see where we get together and hang out.
You and Scaramucci.
I was thinking about some other departments. But it was sudden, and I had to really grapple with what I was feeling at the time, which was in some ways a sense of pride over what we had been able to accomplish in terms of building a team that cared about each other, that was a family, a team that hopefully did some good during our brief time. But it was also, a sense of, there was some anger there as well. I felt that there was more that we wanted to do and that we could have accomplished, and I wanted us to have the chance to do that, and we were building momentum as a team. And then there was a sense of confusion about where I should go and even what I needed. Where you should go really should be driven by what you need. And what I realized is that I had not taken time to really think about what it was that I needed. I had no shortage of people who were telling me what I should do, all with good intentions. These were people who were concerned and said, hey, there's an opportunity here. Maybe you want to do this. Maybe you want to do that. Really well-intentioned, and I'm grateful for friends like that. But what I had to think about was whether I really had a clear sense of what I wanted to do. And I realized I just didn't know. There was a lot of noise, and I couldn't really figure out what the signal was. And I didn't entirely know what would let the noise settle. I thought maybe some time would help. I thought maybe spending some time, particularly with our son at that time, and with my family, and just doing some reading and thinking and reflecting would help. And it did, and all of that helped. But I found myself in a way that might be somewhat familiar to all of you, drawn into action often, into meetings to try to sketch out ideas and plans, into discussions with people about things that we could build. And what I realized in retrospect was that it was my periodic discomfort with uncertainty that led me to those actions. And our ability to sit with uncertainty, I personally think, is an incredibly important skill for us to cultivate. It's one that I've been working at my entire life, and I have a long way to go. But I found that was a skill that I was being pushed to develop, because I needed everything to settle, or to settle a little bit more, for me to really hear like what at a deeper level my soul was calling for. And so that took some time, and a few things emerged over the course of the last year. One is that this topic around emotional health and well-being that I had started to focus on in the later part of my time in office, an issue that really gets at the real causes and drivers of the emotional pain that people are experiencing, that felt true. That felt right. I didn't know exactly how I wanted to address it 6 months ago, although I have more clarity now, but that felt worth investing in and building an effort around. And so that's something that I'm moving forward on now through a combination of writing and looking to build an institute with two of my good friends and colleagues here, Jessica and Anne, and a few others. But there's still more dust to settle, and what I have, some open questions in my head have been, where does clinical practice fit back into this? Like, when do I want to get back to seeing patients? Something I miss, a lot. I talk about patients all the time, the patients I have been privileged to see and whose lives have been so honored to be a part of. But I miss that, and I missed it when I was in office. And I also think about, you think about other things, just thinking about we don't talk about money a lot, right, as a profession. Like when you're moving on and negotiating for jobs, like, do we really talk about salaries and things like that? We don't really talk about it. It seems like a taboo issue. We should discuss it. But money affects all of our lives, and thinking about how we derive income in our lives in a way that feels meaningful, and how much income is enough. These are really important questions for us to talk about. I started asking friends these questions, like, so how are you thinking about your financial planning? Because I'm trying to think about what we should do for our family. And people would often, after being taken aback a little bit, they would often share really thoughtful ideas, including sometimes their confusion. And I would ask them, have you talked to anyone else about this? No. We don't talk about this stuff. But I realized there too, something that has become an issue that I've become more and more interested in, and that I'm actually doing some writing on now, which is that loneliness was actually becoming a problem that I was aware of, not just in the community around me, but in my own life. When I reflect on my time as Surgeon General, I was surrounded by people all the time, all the time. Whether it was at events or in the office or going to meetings or this or that, I was always with other people. But I actually, in retrospect, recognized that I felt lonely at times. And part of that was because some of the core relationships that had sustained me, that we all need in our lives, had been edged out. And I had allowed them to be edged out because I had allowed work to occupy a larger and larger space in my life. And, I could justify that. I could say, you only have a limited amount of time in office. You got to do what you can. It's a once-in-a-lifetime opportunity. But the truth is, we can say that for almost any phase of our life, right? But the longer those relationships dwindle, the deeper our loneliness grows. And I realized that that had been true for me as well. So as I think about what I want to do next, as my wife Alice and I think about that together, what she wants to do, what I want to do, what we want to do together, where we want to live, this idea of community actually has become more and more important to us. A recognition that we cannot be at our best if we are not in a community that we can support and that supports us. And that interdependence, admitting to that, does not make us weak. It in fact allows us to be stronger, because we are at our best when we are with others. We know this from residency training, right? That, I think about, can I share a story about you, Namita? Namita Mota, who some of you know, a wonderful doctor, amazing leader, sitting next to another amazing doctor, Rachel Brody. We were HVMA residents together in the HVMA Brigham program. And I remember Namita coming in one day, and I tell this story all the time to people around the country, and I hope it's okay because I never asked you for permission. I don't name you. But I remember Namita came in one day to our Thursday morning session, and she was really frustrated. It was very obvious. And she threw her sign-out papers down on the table, and she said, "Guys, I'm so upset." And Rachel and I were like, "Why are you? What's going on? Are you okay?" She said, "I feel like everyone always has longer differentials than me at Morning Report. I feel like I can't cite as many papers in the literature as everyone else can. All I can do is sit with patients and make them feel better. That's all I can do." And I reflect on that so often, because her gift, even in those early days of med school and residency, was in allowing patients to feel at home, to feel cared for, to feel embraced, metaphorically and sometimes literally. And what a gift that is. And so for me, this past year has been about rediscovering and rethinking about what those gifts are, those natural gifts that each of us have, the natural needs that all of us have for each other, and thinking about how to actually prioritize that in the next decision that I make. To me, it's now less important whether I run a big enterprise or have a massive salary or have tons of fame or all this kind of stuff. Are all of those things nice? Sure. We should all admit that those things, we might want them at some point in our lives. There's nothing wrong with any of that. But what's wrong is when we subvert our more fundamental needs to those things, when we allow our need for connection, our need for family, to be subverted by that, when we allow our self-worth to be determined by those things. One of the things I think about now as a dad, and Atul and I were talking earlier today about our kids, and I was telling him that he was so smart that he had his kids early in life, and I waited.
And I'm a lot older. We got rid of him.
But one of the things that I think about now a lot for our children is I think about how we are going to instill them with a strong sense of self-worth. And I worry about this because our self-worth is connected to our loneliness. If you don't feel like you're worthy, why do you think other people would want to connect with you, be friends with you, spend time with you? We need to have a strong sense of self-worth, but we are living in a culture where self-worth is determined by what we do and not by who we are. Right? And in a recent study that was done, parents asking them, would you prefer that your kid be academically successful or be kind? 80% of parents said, I would rather them be academically successful if I had to choose. Again, I don't fault those parents per se. They're reflecting a culture that tells us that our worth is dependent on what we do, our title, our institution, our pedigree, and not on who we are, on whether we are kind, whether we are compassionate, whether we are willing to give and receive love in the world. And I think about that, and I don't want my son and my daughter to grow up in that kind of world or in that culture. I don't want their worth to be determined by those kind of whims. And so as I think about the work that I want to do, when I actually think about all of us as a profession and what we can do, I want us to build a world that is less governed by fear, and that is more driven by the opposite of fear, which is love. And how do we do that? Well, I think we each do it differently, but I think we can ask ourselves when we make decisions about what career path we take, about what we say to someone around us, about how we react to a situation. We can ask ourselves, where is that coming from? Is that reaction, is that action coming from a place of love or a place of fear? And if I ask myself that question honestly, I will tell you that there have been a number of decisions I have made over the last few years that have come out of fear. Fear that we need to do something, otherwise we won't make enough impact. Fear that we need to do this, otherwise people will think that we're not good enough. And I look back on some of those decisions and those don't feel good. The decisions that feel really good were the decisions that we made out of love. The decisions that we made, Jessica and Ann and I, when we were in office, that we would never run out of the room after an event, but we would stay to talk to people, because that is how we could both share our appreciation for people, but it's also where we could open our ears and our hearts to hear from them. It was the decisions that we made about what issues we chose to take on, some of which were really hard. Nobody wanted me to ever talk about gun violence because it was so political. In fact, nobody wanted me to go to Flint, Michigan after the water crisis there, because they said it's too political, we don't want you drawing too much attention to it, you know, your office is a high profile, people have higher expectations of what the government should do, and that'll set us up for failure. Nobody wanted us to go to Flint either. There were many things like that that people didn't want us to do. But we knew that we had to go, and those were decisions that were made not based out of fear. Those are decisions that were made that were informed by love in the form of appreciation, gratitude, kindness, compassion. And that's what I want for our kids, for all of our kids, is a world where they feel supported to make decisions out of love, where they feel that love is not a dirty word, where it's not a source of weakness, but is in fact our greatest source of strength and our greatest source of healing. And as doctors and nurses and pharmacists and people who are in the health profession, as health policy researchers who are there to make our healthcare system better, we need to know what our greatest assets are. As wonderful as our medicines and our technology are, we can't focus on those at the expense of losing sight of our most potent and our oldest resources, which are our ability to listen, our ability to be compassionate, and our ability to lead with love. So my ask of all of you, as you think about your lives, since I've told you a bit about mine, is that as you think about the decisions you make, about what step you take in your career, about decisions you make in your relationships, about how you're going to deal with a difficult situation with your patient or with your family, that you think about this choice between love and fear, about what guides you. And I hope that you will choose more often than not to act, to speak, to lead, driven by love. And if you do that, then you will not only create a better community around you, but you will set an example for a nation that is struggling and looking for sources of hope, that wants to believe, despite all the cynicism that you might sense and read about in the news, a nation that wants to believe that things can not only be better, but that there are people who are willing to stand up and sacrifice and make them better. And I want those to be all of us.
Vivek, as you think about We hope you'll come back to this community as you think about where you might want to go. Just know you're welcome into this community anytime.
Thank you so much.
Thank you, everybody.